We have our next presenter, Dr. Ifani, presenting on public health in the topic of personal disposition contributes more than environmental disposition to medication adherence in a medical center in Lagos, Nigeria.
Good afternoon from Nigeria. Good afternoon to the panelists and good afternoon to the attendees and organizers. Thank you for share my findings in a research. Name is Dr. Ifani Ugo Godwin, a medical practitioner turned public health researcher. I'm going to present personal disposition contributes more than environmental disposition to medical patient adherence in a medical center in Lagos, Nigeria. Something has been happening in an environment which we need to investigate. I'm going to look at the introduction methods, results and findings, discussions, limitations. Introduction. Take an introduction. Because of time, the problem of non-adherence to medication is something that has been happening, especially to non-communicable diseases worldwide. It's a challenge because they take these drugs for a long time, and there are so many factors. They get depressed. A lot of things happen, and it has been a problem. But recently, in our environment, another factor was introduced, which we found out among the drugs, especially those on hypertension and diabetes, especially that make up 70% of the patients we see in the clinic. So we decided to carry out this research to know exactly what this new introduction in terms of patients now believe that if they take drugs that will help them, that these drugs are chemicals and they're going to destroy them with time. It is different from the normal side effects people have about medications, but this was a new entrant. So we decided to design a study to find out the extent of this thing that was introduced in the community to non-adherence of these medications. Introduction. Let's go to introduction. Next slide, 5. Yeah. This introduction, this study was taken in Lagos in a health care facility, and it was a kind of trying to find out what had been happening and aiding low adherence to medication among the people who are suffering from chronic disease and require this drug for a lifetime. The low socioeconomic situation, non-availability of drugs, high cost of medication, and paucity of clinics with attendant non-comprehensive health insurance cover made us to focus on these issues that constitute barriers. These are normal issues that constitute barriers to drug adherence. But in our center, these issues have been eliminated because almost 80% of the clients have insurance cover. So, and we are still wondering why these people are still, not adhering to their medication. So that's, made us to design this particular research. The objective of the research, was to improve the understanding of physicians to the management of chronic illnesses. 2, to find out the contribution of personal disposition to barrier to adherence to medication. 3, to compare the effects of personal disposition with that of environmental disposition and determine which of them has a greater influence. 4, to find out the barriers that have high impact on adherence barriers to medication. Then we look at the third question, which was stated as, does the research question. Can we go to the next slide? Next slide, please. Does personal decision, which include negative beliefs about drugs, have more effects on adherence to medication than environmental decision, which includes physical barriers? So we're comparing the physical barriers with the, environmental decision and that of negative beliefs. Personal decision, what we are thinking about, and why we asked this research question was because it was easier to deal with environmental disposition than dealing with personal disposition. Next slide. Next slide. Now we used a questionnaire which was 4 Likert scale questionnaire to recruit 27, we recruited 30, but 27 appeared. So we had this this questionnaire called the Molesky Medication Adherence Scale. And we now gave this out randomly to patients who had this chronic illnesses, and the correct ones filled it and the other ones couldn't do that, were assisted. And their queries were done on kind of a private room, and we now have to analyze these questionnaires. Analyze questionnaires, and next one. We had some, results which, I want to, share with you here right now. The results showed that the lowest education we had there was school certificates. Majority of them were educated. They live in the same environment, and most had insurance cover. 10% of all the people had no, barrier to medication. 90% had one or more barriers. 26% reported more of negative beliefs than barriers, and 43% reported more of physical barriers than beliefs. 23% reported negative beliefs, and physical barriers equally. The age range was 25 to 82, and the female ratio was 16 to 11. For those that reported negative beliefs, 6 out of 8 showed low medication adherence, and 6 out of 13 that reported physical barriers showed low medication adherence of 46%. The younger one reported more negative beliefs and barriers than the older ones, and they reported taking more than 2 types of medications, and some were taking more than 3. More than half of the participants had both diabetes and hypertension, while about 25% had only one condition. Now, I have some tables that showed gender distribution of femaleness. I have some tables and charts. Now, we try to analyze the results. We had a formula. I want to test the hypothesis and know whether we can accept the null hypothesis that said there was no difference, or the alternate hypothesis that showed there was significant difference. So we used students' t-test statistical analysis for the mean of difference of these two groups using the SSP, SSS analysis. And when we did that, we discovered the next slide at calculation, we found out they had a p value of 0.025, and that was below 0.005, which showed that the null hypothesis was rejected. The next slide. Fine, next slide. Yeah, so it was rejected. That means that personal disposition contributed more barriers to adherence to medication than environmental disposition. All the charts that I had showed that questions on environmental had a mean of 6.93 compared to 5, that on personal disposition has 7.56. Next slide. The disease burden of chronic disease in environments is really increasing and affecting the younger age group more than the elderly, maybe due to urbanization or access to dense energy food. In this study, both physical barriers and negative beliefs account for the low medication adherence incidence in environment linked to poor health outcome with this environment. 90% showed there was one kind of barrier to adherence. So that means that it's a very serious problem in our environment. Now, negative believers eating deep into the fabrics of our society. In rural areas, due to lack of medical facilities, patients relied on alternative medicine for their cure. So we had, a situation where negative belief that played a major role in, affecting the health of our people. The next slide. So the new dimension, some of the new dimension of this negative health belief has made me to suggest that we have to integrate some models, some health, models to be able to tackle this problem. And these health models is what we should integrate seriously into our system to be able to combat this, problem. It's a malady, and the two models I propose here is a health belief model and trans-theoretical model as a personal tool for every physician that's taking care of these patients. It will individualize the care and be able to follow them up to have a change. It's easier to intervene in the physical barriers than in the personal disposition. The belief system is one of psychological negative belief. It has been debunked. We use all kind of means to debunk those, things that can be able to affect our, So, next slide. Let me round it up. Next slide. The study has some limitations. It was one hospital, one center study, and I think we should do more in future to involve more hospitals. 2, it was a very short, study where we have had only very few participants in that study, and just participants. There were 2 attritions. So it's difficult to extrapolate this kind of population, to larger population because the power is small. But what it has done is to create awareness that this negative belief, which is part of personal disposition, is a big problem that we need to investigate more. Next slide. Conclusion. They have their collective impacts. If they have their collective impact, both the physical barrier and the personal disposition, they have their impact on the people, and this impact has been investigated. If you look at other works done, they have been trying to equate these two as working together, and the reported belief system is eating deep. There's a shift in paradigm. Before it was more of physical barriers where people cannot get their drugs, they have no money to transport themselves, the place is far. It's now getting into the society that people report that if they take drugs, that is going to destroy them in the next 10 years, 15 years, and that has been a hindrance to effective management of patients with these chronic diseases. Thank you for listening.
Thank you, Dr. Ifeanyi.
Yeah.
Yeah, thank you for your valuable presentation. Attendees, we are enabling the polling session on behalf of Dr. Ifeanyi's presentation. You can participate by polling, and also if you have any questions on the presentation, you can put it on the chat box. Dr. Ifeanyi would refers attendees. You can participate on the poll. Also, you can post your questions on the presentation. Dr. Ifeanyi will answer on that. Dr. Ifeanyi, how do you rate the environmental disposition at Nigeria for medical centers? How do you suggest on that?
I didn't get you.
No, how do you suggest the environmental medical centers in Nigeria? How do you suggest those medical centers in globally?
The medical centers?
Yeah, the environmental medical centers. How do you recommend those medical centers out of Nigeria?
Well, the medical centers in Nigeria, the financing of medical center, if it's what you are talking about, the financing is more of out of pocket than insurance cover. The medical center we used had 80% of clients who so, and I feel that we can organize medical centers around the vicinity. We can coordinate them and do a study involving a lot of medical centers, and that should be the next thing to do about this survey.
Dr. Ifeanyi, you have another question, higher than 75% out of pocket expenditure remains the key barriers to accessing health services in Nigeria, dealing with the cohort of people with access to public health insurance with concern valuable factors that influence adherence. How relevant could your findings be across communities where access to health insurance is limited?
Yes. Now it's true. That is what the physical barriers, took care of. Physical barriers we know is there already. There is no problem about that. We are talking about the health belief, the belief system that has come to worsen the situation. We have a situation on ground already. People don't have access to health care, but even the ones that have access to health care, this belief system is worsening their problem. So we are looking at it as even those who have access, who have opportunity to be the 5 to 10% of people who have access to health care, they still have another problem on top of what physical barriers that he is asking of. Is that health belief system, which has spread like a cancer in the fabrics of our healthcare system.
Thank you, Dr. Godwin. Thank you, Dr. Godwin. Thank you so much. Please share your email ID in the chat box so that if any presenters need some discussions or any clarifications or concerns, they will write to you. You can respond to them.